If a teenager sits in front of you in the CASC, barely speaking, barely eating, not going to school, and all you get are one-word answers, how would you assess them? Assessing a depressed adolescent. Hi everyone, I'm Dr. Clarke, MRCPsych, and welcome back to Pass the CASC. Today we're breaking down a station many candidates find intimidating. Assessing a depressed adolescent who is withdrawn, not eating, and disengaged from school. This is one of the most quietly difficult stations in the MRCPsych CASC. This station isn't about racing through symptoms. It's about trust, emotional safety, and developmentally appropriate communication. By the end of this video, you'll have a clear, exam-ready structure for approaching this station calmly, assessing risks safely, and scoring highly in both communication and management. One quick clarification before we start. Even though the CASC uses adult actors, you can still be asked to assess a child or adolescent. Examiners expect you to treat the actor as the age stated in the task, and they're marking how you communicate, not whether the actor looks 15. CAMHS stations are challenging because the patients are often quiet, emotionally heavy, and don't respond well to rapid questioning. This station isn't about ticking boxes. It's about creating enough emotional safety for a young person to speak at all. You are a psychiatry doctor seeing Joan, a 15-year-old referred by her school. She has been feeling hopeless, withdrawn, and has been refusing to eat. Take a sensitive, age-appropriate history focused on mood, eating behaviour, and social functioning. If a patient goes quiet in the CASC, that does not mean you're failing. Silence, short answers, and I don't know responses are often part of the presentation. Your job is not to fill the space, it's to sit with it. Examiners are watching how you respond to that silence, to see if you can stay calm, patient, and emotionally containing. One of the biggest mistakes in this type of scenario is rushing. Remember, a silent patient does not mean that you are failing the station. Tolerate short answers from your patient. And keep in mind that engagement and rapport building must come before exploration of symptoms. Common pitfalls in this station include firing questions like a checklist, ignoring emotional withdrawal, avoiding asking about suicide and performing a thorough risk assessment, confusing depression-related weight loss with an eating disorder, and speaking as if you're in an adult clinic. Remember, this station primarily rewards containment, clarity, and trust. Hi Joan. My name's Dr. Clarke. Thank you for coming in today. I know it can feel a bit awkward talking to someone new, especially when you're not really sure what to say. There's no rush. We can take this at whatever pace feels okay for you. I've been told things have been a bit harder for you lately, and my job today is just to understand what that's been like. Before we go on, I just want to check. How are you feeling about being here today? Explicitly normalizing hesitation reduces pressure and builds trust. When a teenager says, "I don't know," that is not avoidance. It's often the most honest answer they have. Challenging it by repeating the question, rephrasing, or pushing for clarity increases pressure and costs rapport, losing you valuable time and marks in the exam. Can you tell me a bit about how things have been for you over the past few weeks? When you say you've been feeling hopeless, what does that actually feel like day to day? Are there things you used to enjoy that don't really feel worth doing anymore? How has your energy been? Do even small things like getting out of bed or showering feel exhausting some days? If a young person struggles to label emotions, offer examples, don't just repeat the same question. Try and remember to explore these core depressive features. Low mood, anhedonia or loss of interest and pleasure in activities, anagia or lack of energy and drive, sleep and appetite changes, reduced cognition and attention span, feelings of hopelessness, worthlessness and guilt, and thoughts of death, self-harm and suicide. You mentioned feeling like a burden sometimes. What kind of thoughts go through your mind when you're feeling that way? Do you ever blame yourself for the way things are, or feel like you've let people down? When you think about the future, does it feel hard to imagine things getting better? Beck's cognitive triad, or the negative triad, describes 3 core negative thinking patterns linked to depression: a negative view of the self, I am worthless, the world, everyone is against me, and the future, nothing will ever get better, which fuel each other in a cycle of negative beliefs. How has your sleep been recently? Is it more that you struggle to fall asleep, or is it that you wake up early still feeling exhausted? This section is a key discriminator for the station. It's really important to differentiate depression from an eating disorder. This is where a lot of CASC candidates quietly lose marks. Weight loss does not automatically mean an eating disorder. Explore eating neutrally without assumption. Intent matters. Ask whether food has lost its appeal, or whether there are worries about weight or body shape. Then reflect it back clearly. From what you're saying, it sounds like this is more about not feeling hungry or motivated, rather than trying to control your weight or appearance. Functional impact often indicates the severity of the illness. Remember to ask about school attendance, concentration and attention span, and peer withdrawal. How has going into school been recently? Are there days when it feels too hard to go in at all? When you're not in school, what does your day look like instead? When you're in lessons, can you concentrate, or do you find that your mind drifts a lot? Do things that used to feel manageable, like homework or tests, now feel a lot harder? How has being around friends been recently? Have you found yourself pulling away from people, even those that you used to be really close with? It sounds like being around others feels exhausting right now. In CAMHS stations, I'm listening just as much for what they're not able to do anymore as for how they're feeling. Many candidates rush through symptoms like a checklist, but functional impact is what tells the examiner how unwell this young person really is. You must ask these questions, and you must ask them calmly. It's not asking about suicide that loses marks, it's how you ask. I introduce this by saying, I ask everyone these questions when they're feeling this low, because it helps me keep people safe. Then I differentiate between passive and active thoughts. I ask about frequency, progression, and any past behaviour, calmly and directly. Examiners are not just listening for the presence of risk questions, they're watching whether you can ask them without increasing distress. This means slowing down, softening your tone, and making it clear that these are questions you ask everyone to keep people safe, not to shock or alarm them. Sometimes when people feel really low for a while, they have thoughts about not wanting to be here anymore. Has that ever happened to you? Are those thoughts more about wishing you could disappear or fall asleep and not wake up? Or have you ever thought about hurting yourself? When those thoughts do come, how often do they tend to show up? Are they there just occasionally or most days currently? Do the thoughts pass on their own, or are they getting stronger and harder to push away? Have you ever done anything to hurt yourself in the past? Or ever found yourself preparing to, even if you didn't go through with it? Thank you for telling me. I know it's not easy to talk about. Do not overreact, reassure prematurely, or escalate emotionally. When things have felt overwhelming before, what has helped you to cope? Is there anyone or anything that helps you feel even a little bit safer? Risk is higher when protective factors are absent. Your summary can make or break a CASC station. It isn't just a recap, it's where examiners see containment. A high-scoring CASC summary does 3 things in this order. First, reflect what they've told you, calmly and accurately. Second, Validate how difficult that's been for them. And third, contain the emotion by slowing down and reassuring them they are not dealing with this alone. If you rush the summary, minimize it, or jump straight to solutions, you lose marks. Before we finish today, let me just check that I've understood you properly. Over the past few weeks, you've been feeling really low and worn out. School, eating, and seeing friends have started to feel overwhelming, so you've been withdrawing and keeping more to yourself. You've also had times when you felt quite hopeless, and you've had some thoughts about not wanting to be here anymore. But you haven't acted on those thoughts, and you've told me about them today. Thank you for being so honest with me. I know that wasn't easy. We don't need to sort everything out today. What matters is knowing that you're not dealing with this on your own, and that we're taking your experiences and your safety very seriously. Before we finish, does that summary sound right to you? Is there anything important you'd like to add or correct? Here is my roadmap to success in this station. 1. Engage the patient gently. 2. Normalize silence. 3. Explore mood openly. 4. Assess eating without assumption. 5. Explore school and social impact. 6. Ask directly about risk. 7. Identify protective factors. And 8. Summarize and contain the emotion. If you can sit calmly with a distressed adolescent, ask difficult questions gently, and summarize with empathy, you will score very highly in this station. This station rewards clinicians that can tolerate quiet distress, rather than rush to fill it. If this video helped you, subscribe to Dr. VT Clarke, and comment with the station you'd like me to cover next. Thanks for watching Past the CASC. If you found this video helpful, subscribe to Dr. VT Clarke for more exam-focused psychiatry teaching. And if you're looking for a complete CASC revision toolkit, download Cascade, the app, now.